Hi everyone, welcome back to the Med Student Notes. Today we're going to talk about thrombotic thrombocytopenic purpura. While it's quite a mouthful to say, it's actually super easy and interesting, so let's get into it. This is basically a story of something called the von Willebrand factor. What is the von Willebrand factor? It is a glycoprotein, simple enough. Where is it produced? It's produced in the megakaryocytes, which are precursors of the platelets, remember? And it is produced in the endothelium. Post production, it is stored in the alpha granules of platelets. Okay, and Weibel Pollard bodies of the endothelium, the endothelial cells. What is the purpose of von Willebrand factor? What does it do? Let's take a look at microvasculature like arterioles and capillaries. Now, some damage has occurred to the endothelial layer, okay? So, when some damage has occurred to the endothelium, the underlying subendothelium is going to be exposed, right? The subendothelial collagen right here. In that case, von Willebrand factor is released from the endothelial cells. Now, think of von Willebrand factor as this giant sticky magnet that attracts platelets. So, with the help of GP1B receptors on the surface of platelets, von Willebrand factor attracts all the platelets and they come stick here, forming a platelet plug. Okay. So, this damage that has been incurred has now been fixed with the help of a thrombus. Like we said, this von Willebrand factor is kind of this large glycoprotein and it can form multimers. Okay. A lot of them can kind of form together. There is an enzyme called ADAMTS13 which helps you cleave these giant multimers of von Willebrand factor. Because otherwise, if we let them keep floating through the circulation, platelets are going to come and keep sticking to it, right? And there's no damage that's occurred here. We don't really need thrombi to form. But just because these von Willebrand factor multimers are floating through the circulation, our platelets are going to come and stick to this. So, what is going to happen? Platelet plugs are going to form unnecessarily, right? So we're going to have these platelet plugs forming incessantly and unnecessarily, which is going to effectively occlude the vasculature. Now, when your red blood cells and the rest of the blood wants to travel through, it can't because the blood vessels have kind of been occluded because of these platelet plugs. So, what's happening here? We are losing platelets unnecessarily to these platelet plugs, right? So, thrombi are forming, a lot of them, and we are also losing platelets. So, thrombocytopenia. So, in case where ADAMTS13 is deficient, it is not present, these multimers of von Willebrand factor are going to be causing platelet adhesion, platelet aggregation, and thrombi, leading to thrombotic thrombocytopenic purpura. I hope that was clear. Something that you want to take note of here is like we said, when RBCs are trying to pass through this circulation, it's going to be hard because the microvasculature is occluded, right? So, what happens is because of the shearing stress that is created, RBCs are going to be kind of being pushed through, and this causes them to break down. That's why you see MAHA in thrombotic thrombocytopenic purpura, which is microangiopathic hemolytic anemia. It's quite self explanatory. Microangiopathic because microvasculature like arterioles and capillaries. Hemolysis is happening because while blood is trying to squeeze through this occluded vasculature, the red blood cells are going to be breaking down because of the physical shearing stress. So, we'll also see anemia in it. ADAMTS13 deficiency can be acquired or congenital. Acquired is the most common, like 95% of cases are usually acquired ADAMTS13 deficiency. Why does it get deficient? Because the body forms auto antibodies against this particular enzyme. So these auto antibodies will keep breaking down ADAMTS13, which will cause the deficiency. In some cases, gene mutations will cause a congenital deficiency of ADAMTS13, but this is much less common than acquired. So, some risk factors that can make you more vulnerable to TTP are systemic diseases like SLE. No, SLE is already an autoimmune thing, right? So, it can just cause this as well. Some infections could lead to this, malignancy could cause this, HIV could cause this. Again, when I'm saying cause, I mean these things could make the body a little more susceptible for the formation of these autoantibodies. I'm not saying that these are the direct causes of the disease. Some drugs can lead to it. Pregnancy can also make you more vulnerable to TTP. Let's look at the clinical features now. See, the beautiful part of medicine is when you understand the pathophysiology quite well, it's very, very easy to understand what the clinical features could be. So, what have we spoken about? Platelets going down. It's in the name. So, you will see low platelet count. You will see thrombocytopenia. And what will thrombocytopenia cause? You will see kind of easy bruising, petechiae, purpura, mucosal bleeding can be happening. So if a person gets a minor injury, like there's a little cut, but they're bleeding for a very long time because the platelets are deficient, right? And then we already discussed that it can lead to microangiopathic hemolytic anemia. So low RBC count. And what can that cause? It can cause fatigue, dyspnea, and because this is a hemolytic anemia, it is also likely for you to see jaundice in this case. It can cause fever because all this breakdown in the body, all this disturbance that is going on systemically, it can lead to this, it can lead to a fever response. So when we're talking about arterioles and capillaries, when we're talking about this microvasculature, some organs are going to be particularly susceptible. If you form these platelet plugs in the arterioles and capillaries that supply the kidney and the brain, the microvasculature in kidneys will be affected, which can lead to renal disturbances. And you can see it in the form of hematuria, proteinuria, CNS dysfunction can happen, of altered mental status. You can see seizures, you can see focal deficits. In particularly awful cases, you could see stroke. In milder cases, you could see like headache. And this is basically the pentad of features that you will see in TTP. That's why I made the little pentagon. Although you remember this pentad for TTP, you want to know that in medicine, in real life cases, and even on exam questions, you may not always see all these 5 features. Like your patients aren't going to present like, the exact textbook features of everything that you study. More commonly in real life, patients are going to be mostly just presenting with thrombocytopenia and hemolytic anemia. This is a differential that you want to keep in your head when you see a patient coming in with jaundice and you see low platelet counts and they're fatigued. Maybe they have a little bit of fever. This renal disturbance in CNS is not going to be seen in every single case. But yes, you'd want to check for acute kidney injury if they're talking about any hematuria, or they seem to be, or they're saying they're not going to the washroom enough, they're not peeing enough. Okay, so let's go down to the labs. When you get a CBC from a patient, you're obviously going to see a decreased platelet count. Typically, it's going to be less than 30,000. They're going to be that less. You will also see decreased hemoglobin. You will see decreased RBCs. On coagulation studies, there could be a very, very mild increase in PT and PTT, but most of the time, they're going to be normal. Von Willebrand factor carries factor 8, which plays a role in the intrinsic pathway, so there could be a difference, but mostly normal. Because the platelet number is very less, you will see an increase in bleeding time. And because of hemolysis, you will also see an increased number of reticulocytes. Your basic hemolytic anemia results. And decreased haptoglobin. You will see an increase in LDH. Because of the hemolysis, you will see an increase in indirect bilirubin or unconjugated bilirubin. Because, the RBCs are undergoing breakdown. On a basic metabolic panel, you can see increased blood urea nitrogen and creatinine because of the damage to the kidney if it's there. On urine analysis, you can see hematuria and proteinuria. To confirm that it is TTP, like you got all these labs and it seems to you that this is probably TTP that your patient has come to you with. Then to confirm, you'll want to get an ADAM-TS13 testing. And if this is less, if this is deficient in the body, then you're good to establish the diagnosis, right? And additionally, because we have discussed some risk factors here, you may want to get an ECG, you may want to get a CT to see if there's any stroke that's happening. Again, these are things you want to get if there are associated clinical features. Like you're not going to get a CT in a patient that's completely normal, they're just slightly jaundiced, they're telling you that they're bruising easily. If a patient is coming to you with altered mental status, then you want to go for these measures. And if you see any SLE like features, then you'd want to just check for that as well. Okay? Now, how do you manage? Oh, by the way, on a peripheral blood smear, you would see schistocytes, right? Schistocytes will happen because, again, we have our blood vessel, right? We have these platelet plugs. Blood is trying to go through, blood is trying to squeeze through, and because of that, it's being broken down by this extreme shearing stress. So it kind of fragments, right? The RBC kind of fragments, and the RBC will end up looking like this, and these are schistocytes, and you will see this on peripheral blood smear of a patient like this. Something that I want to quickly highlight here is that Coombs test will be negative in TTP. Now, you may be wondering that we already established that autoantibodies are going to form. So, Coombs test is something that tests for autoantibodies, right? So, shouldn't it be positive? But the autoantibodies here are going to be formed towards ADAM-TS13. Normally, Coombs test is very specific for antibodies against the blood cells. Here, hemolysis is not happening because of antibodies by itself. Hemolysis is happening due to a mechanical reason, right? Which we've already discussed. So, Coombs test is going to be negative in TTP. However, in autoimmune hemolytic anemia, where there are going to be autoantibodies directed against the RBCs itself, there you will see a positive Coombs test. Okay, so make sure that this is not something that you get confused about. Before we move on to the management, there's another thing that I want to quickly point out. We discussed that acute kidney injury can take place in TTP, right? Now, something that I was confused about previously, and something that I think med students would maybe get a little confused about, is the fact that you would expect the acute kidney injury to be pre-renal, because occluded vasculature, so the kidney is not being perfused properly. But that's not the case, because the arteries that are supplying the kidney itself, the renal arteries, they're quite big. It's not particularly microvasculature. Here we are talking about microvasculature. So what is going to be affected are the small vessels inside the kidneys, right? So when this happens, it's not going to be pre-renal AKI. It's intrinsic kidney injury. It's going to be renal AKI. Okay? Because it's the vessels inside the kidneys that are being affected, and the kidney is, because of that, not being able to function properly. So that's something that you want to take notice of. It would be very generic to think, okay, yeah, there's AKI, and leave it at that. But you want to know what sort of AKI. You want to know why Coombs test is negative in this case. Okay? Okay. So, first thing you want to do when you manage is do your fluid management properly. And because of intrinsic kidney injury, there are going to be electrolyte disturbances. Also, because of hemolysis, also there are going to be electrolyte disturbances. When there is hemolysis, the RBCs break down, which can release potassium, remember? So there can be something like hyperkalemia. And because of problems with the kidney itself, it may not be able to secrete H plus properly. So you could be having some acidosis in the body. You also have elevated LDH because of this. So these sort of things will cause some electrolyte and acid base differences. So you want to take note of that and replenish fluids accordingly. When it comes to transfusions, see, again, you want to think about why this disease is happening, right? Platelets are there. It's not that platelets aren't there. It's because von Willebrand factor is causing these platelets to stick here, and that is leading to the cascade of problems that follow. So if you're just giving more platelets to the body because you're like, oh, there's no platelets in the body, so I'm going to give transfusion so that there's more platelets. What will happen? Your von Willebrand factor is not going to go. ADAMTS13 is not there. Your von Willebrand factor is still here. You give more platelets are going to stick to the von Willebrand factor, more thrombi are going to form. So you will be causing more damage if you're just giving platelet transfusions because platelets are low. So you do not want to give prophylactic transfusions. When would you want to give a transfusion? You'd want to give it therapeutically if there's a patient that's bleeding right now. Like right now, they're bleeding and they need platelets for the bleeding to stop. You want to stabilize a patient that's kind of deteriorating now. Or if they need an invasive procedure like some surgery, or if there's some really bad trauma. So you can't afford to just let them keep losing blood. That is when you can give a therapeutic transfusion. So you will individualize this to the patient, okay? And when you are giving an RBC transfusion, because we've seen hemolysis is present, and if the anemia gets really bad, you can give an RBC transfusion, but you follow the usual rule of you give it if the hemoglobin is less than 7 grams per deciliter. Normally, how do you manage this? What you want to do is give plasma exchange therapy. So when you do plasma exchange therapy, the von Willebrand factor multimers are going to be taken out, and you're giving in the proper plasma without all the built up thrombi and the hemolytic products, all of that. So the most important and the best thing to do for this is plasma exchange therapy. You can also give glucocorticoids like prednisone. Like we've done in ITP, you can consider monoclonal antibody drugs like rituximab, and there's something also called caplacizumab. Now, this drug is particularly kind of amazing because it blocks the interaction between von Willebrand factor and GP1B. This is on the surface of platelets, and this is the reason that the platelets form, right? The interaction between these two. So this drug actually blocks this. So it's kind of an amazing drug, and it can be used in acute situations where you know that it's very likely that this patient has TTP. So what would the complications of TTP be? We've spoken about the kidney manifestations, and if there's progressive kidney damage, these episodes keep happening, it could lead to chronic kidney disease and end stage renal disease. So if your end organs aren't being perfused properly, like the liver is not being perfused properly, it could lead to transaminase elevations. Pancreas, if the pancreas is damaged, it could actually cause diabetes mellitus. It could be like transient or long lasting, which is bad. If the heart is not perfused properly, there can be ischemia. If your gastrointestinal tract is not being perfused properly, there's microvasculature damage in there as well. You can see bowel necrosis, you can see hemorrhagic colitis, and CNS we've spoken about. You can see seizures, strokes. So this is a brief list of the complications. So I think we've discussed about thrombotic thrombocytopenia pretty exhaustively. I mean, as far as a med student should know anyway. I usually hope you liked the video, and please comment if you liked it. Please like, subscribe, share, and thank you very much for watching. Have a really, really nice day.